Good afternoon. I'm Dr. Dugmajian, CEO and founder of Duke Spine Institute. We are broadcasting for you live spine surgery today on January 23rd, 2025. Our patient is actually from Florida, I think, right?
Yes. Yep.
Yeah. And he has basically a herniated disc at L4-L5 with bulging back to pinch the nerves. He's got leg symptoms where he's getting numbness, tingling, pain, and weakness in his legs. He has numbness and tingling in his feet. The symptoms were dynamic, meaning they're worse when he's standing and walking, and they get better when he's getting the pressure off the nerves. We're going to give you a numbing injection real quick. Little numbing medicine right here. Sorry about that. Yep, I know. His surgery will take about 45 minutes to an hour. We are streaming live on Facebook, YouTube, Twitter. No, it's X now.
Yeah.
And LinkedIn.
Correct.
There's a few other platforms I haven't quite learned yet.
Instagram and Kick, and we have a few more coming.
There you go, Instagram and Kick. So if you have questions during the surgery, feel free to ask. I'll do my best to answer them for you. All right, so we are going to go for the L4-5 disc. And Jordan, you want to show us the L4-5 disc? Shot? Yep, that is correct. All right. So we are a little bit higher than I want to be. I'm going to move down just a little bit. We're going to put some numbing medicine in the subcutaneous tissues, the muscle, the fascia, because they are pain-sensitive structures. The patient, we want him to be comfortable while he's having his surgery. He is going to be asleep, but only with sedation, and the more numbing medicine I give him into his soft tissues, the less that Dr. Berndes needs to give him to sedate him. It's always better to sedate less. Do you think we're off on WAG there? I know that the 4 looks good, but I'm just talking about 5. Maybe we can compromise and get just a little bit more WAG. Shot? Everything okay, Dr. B? Yeah. Maybe I would. And you're welcome to ask questions during surgery. I'm going to keep operating. I think that's pretty good, Jordan. The problem is the patient has some listhesis. He also has some scoliosis at the L4-5 shot, and he's got facet arthropathy. Give me an AP, please. AP is a front back X-ray. I want to check the position of my needle. Yeah, look at all that arthritis there. My needle is literally touching a bone spur. Can you guys see that, Henry?
Yes, we can.
This is a severely degenerated level. I'm going to have to come in from a different angle of approach. I'm going to have to come in slightly more lateral and try to get around this bone spur. Shot. Shot. You can feel the arthritis from that facet joint. Shot. Shot. That is better, much better. Shot. All right, when I say shot, what I'm asking is for Jordan to take a picture. Shot. Thank you, Dr. Berndes. I love that he is comfortable sleeping. Yeah, that's perfect. Shot. Almost there. Just need a little bit more. I can feel all this scar tissue from the chronic inflammation. Let's go AP. Yep. Shot. If you have questions, feel free to ask me. Go ahead.
No current questions, so we do have a comment coming from a previous patient saying that they had a surgery with you in June of 23, and they have no more sciatica and leg pain, but unfortunately they still do have back pain. I recently have epidural steroid injections to L4-5, 5S1, and medial branch block done. I still have the back pain, but when I get the steroid injections, I have no more pain for 4 days.
Yeah, that's great. So what you're probably doing is getting back pain from something other than what I treated. Because if you watch the next video we're about to do, you'll see there are 30 different causes of back pain. And we may have fixed 2 or 3, but you have others. And we have not yet fixed those others. But if you come back to Duke Spine, we can fix them. My advice to you is get another free MRI review done. If you had a scheduler back in 23, talk to your scheduler. If it was Richard, give him a call. If it was Kim, give her a call. Tell them that you're having back pain. You want to do another MRI review, and you want to, AP, you want to figure out what's causing your back pain. But I can guarantee you it's not coming from where I fixed it. And if it is, that means you did something probably you shouldn't have. But we don't have people having back pain from the areas that we fix.
They just came up with a question relating to this, saying they had Bertolotti's syndrome. And my question to Dr. Duke is, can Dr. Duke help me remove Bertolotti's syndrome transverse process bone out endoscopically? Thank you.
No, I can't do it endoscopically. I really cannot. I can do it open, but there are other doctors that can do it open as well. And my surgery for that is not special in any way. I'm happy to do it for you, but I would recommend you stay closer to home, wherever your home is.
Las Vegas.
Las Vegas, yeah. I would recommend you get it done in Las Vegas because it's closer to home. But I'm happy to do it for you if you want to travel, but there's nothing special about my technique that's better than anybody else's when it comes to open surgery like that for Bertolotti's. It's the same as everybody else's. All right. So happy to do it, but I just don't want you thinking I can do it arthroscopically when I cannot. Look at that massive arthritis of the facets. You guys see that?
Yes, we do.
It's literally on both sides, like a giant cannonball. There it is. And show us the next level up so you can compare it. See, there's none of that at the next level above. It's just this level because he has what's called a pars defect, where he has a cut through the bone, basically, and it's allowing the bones to slip a little bit. It's called a grade 1 spondylolisthesis. But that's not causing his pain. What's causing his pain and symptoms are the herniations associated with it. All right, we are almost there. There's one. Don't move. Almost, you don't have to put him to sleep. Shot. Beautiful. So we are able to get around all that bone spur by going more lateral and aiming more posterior. All right, are you comfortable? Are you comfortable? Don't move. Can you hear me? So L4-5 is the disc we're fixing. Again, he has back pain, but he also has leg symptoms. And it's the leg symptoms I asked him, that's what bothers him the most. It's pain shooting down the legs. We call it neurogenic claudication. Worse when he's standing, walking, better when he's sitting. And he's got numbness in his legs and some weakness and tingling. So he's got a lot of radicular symptoms. Okay, are you awake?
How are you doing, my friend? You okay?
Sean?
Okay, don't move. We're just going to ask you a
Oh yeah,
question.
he's weak. How bad is that on a scale of 1 to 10? How high? How high did it go?
Number.
10? All right. Is that where you get your pain? Is that where you typically get pain? All right, good. He said yes. So that's 10 out of 10 concordant. When you wake up, that pain will be gone, my friend. It will be gone. Great news. We just confirmed that the L4-5 disc that we're operating on is the cause of his back pain. It may not be 100% of the back pain, but it's going to be most of it. And that that's the pain he typically gets every day. So fixing this disc is going to make a big difference for him. Thank you, Dr. B. Let me know when I can proceed. And we will take questions, but we're going to show you our 30 causes of back pain video so that you guys can understand not one thing causes back pain, but there are 30 potential causes. Everybody's different. However, the average patient has 4 causes. Bertolotti's syndrome is one of them, but it's extremely rare. I think I've seen that once or twice in my entire career as the cause of back pain. It's extremely rare. Our friend from Vegas that was mentioning it is probably the only patient I've seen with it that causes pain. Happy to treat it. I don't know that it's going to work. I mean, no matter who does it, whether I do it or somebody else does it. I wish I had a crystal ball. But if that's the cause of your symptoms, then I agree with you. Surgery to remove the extra whatever connection between the L5 transverse process and the sacrum is probably a good idea. Shot? But I would still recommend your free MRI review just to verify that's the problem. Shot? And it likely could be. I'm not saying it isn't. I'm just saying it's good just to double check. Our MRI review is free. You don't have to pay for it. And, maybe something else will turn out during the exam. Maybe you have something else besides Bertolotti. So, if I remember correctly, it probably is Bertolotti based on our last time we saw you. But it's possible that you got a piriformis or a sacroiliac. All right, you going to play 30 causes?
Of course.
Let's do it. I'm Dr. R. Duke Majan with the Duke Spine Institute, and we're going to discuss 30 causes of chronic back pain. Chronic back pain is back pain that lasts longer than 6 weeks, and there are 30 causes of chronic back pain. The most common cause is going to be a disc injury. Disc injuries such as disc herniations, disc bulges, disc ruptures, degenerative disc disease account for 86% of chronic debilitating back pain, and they are totally fixable with the proper treatment. The best treatment for disc injuries is Duke laser disc repair. Let's take a look at the 5 lumbar discs that can be injured. The most common disc to be injured is L4-5, followed by L5-S1, then L3-4. The L1-2 and L2-3 discs are far less commonly affected. Next, we have facet joints. Facet joints are small joints located behind the discs in the back of the spine. There are 10 facet joints, each paired left and right, L1-2, L2-3, L3-4, L4-5, and L5-S1. The most common facet joints to cause chronic back pain are L4-5, followed by L5-S1, followed by L3-4, in that order. After the facet joints, which account for approximately 10% of chronic back pain, we move on to the sacroiliac joint. The sacroiliac joint accounts with the piriformis muscle for approximately 4% of chronic back pain. The sacroiliac joint is a joint located between the tailbone or sacrum and the iliac bone. There is a left and right sacroiliac joint. In this diagram, you can see the joints turning red, indicating inflammation and pain either in the left or right sacroiliac joint. These sacroiliac joint injuries and pain can be treated most effectively with the Duke plasma rhizotomy of the SI joints offered at Duke Spine or Duke Joint Institute. The fourth most common cause of chronic back pain is a piriformis muscle injury. The piriformis muscle is located in the buttock, and there is a left and a right piriformis muscle. The muscle gets torn, unfortunately, when people bend the wrong way. This usually occurs in patients with orthopedic problems such as hip pain, knee pain, or back pain. By bending improperly, they put the muscle under too much stress and they tear the muscle. The torn piriformis muscle causes severe debilitating pain in the top of the buttock. There is a left and a right piriformis muscle, and this can be treated most effectively with the Duke piriformis muscle release. This is performed percutaneously with a 4mm incision. The sciatic nerve does run through the piriformis muscle, and many patients with piriformis muscle syndrome also have sciatic pain down their legs, with pain, numbness, tingling, and weakness in the leg that's affected on the side of the piriformis muscle. Piriformis muscle can be treated with injections such as steroids, Botox, PRP, or stem cells. However, those injections always wear off and the patients end up coming back with the piriformis muscle pain that reoccurs. The most definitive treatment for permanent relief of piriformis syndrome is a piriformis muscle release. Next, injuries to the bones of the spine touches the vertebral bodies with trauma can cause fractures of the vertebral body. Vertebral body fracture is diagnosed with X-rays or CAT scan or MRI, and they're treated with injection of cement into the vertebral body. Looking at the vertebral bodies, the most common to be affected is L1, followed by L2, then L3, L4, and L5. The sacrum can also be fractured. Finally, the coccyx is the last cause of chronic back pain. You can see in the diagram the red coccyx at the bottom. This comes usually from an injury where the patient falls on their bottom, sustains pain at the tailbone, and this can be treated with injections of the coccyx ligament. These are the 30 most common causes of chronic debilitating back pain, the most common being the disc, causing 85% of chronic back pain, followed by the facet joint, causing 10% of the chronic back pain, followed by the piriformis muscle and sacroiliac joint, which cause 4% of chronic back pain, totaling 99% of chronic back pain, which is totally fixable and curable with the right treatment. Thank you. I'm Dr. Duke Majan. Thanks for joining us. Welcome back. You can see from our video 30 different things that cause back pain, chronic back pain. We are inside the herniation right now, and I am zapping away scar tissue associated with the herniation, that white stuff. But we did see earlier the actual normal nucleus in the center of the disc, something we almost never see in our surgeries, is normal nucleus. Okay, I'm going to see if I can find it again just to show you guys. It's pretty cool. It's way down there. Let me see. All right, let's see if I can clean this up. It's in the middle of the disc, and it's normal nucleus, and it's white, and it's kind of, we started pulling out. It's right there, just underneath that little bit of blue. You guys see it right there, the white? That's
Yes, we
normal nucleus pulposus. Uninjured, undamaged, undegenerated at L4-5 in this patient. How old is this patient?
70.
He's 70 years old, folks. So it shows you could be 70, 80, whatever years old and still have a normal nucleus in the middle of your disc. He does. It's not that we're here for. It's the part that's in the back where the tear is. Remember, the Duke laser disc repair is not a discectomy. It's an annular debridement. We are cleaning the tear that has herniation in it. This scope is a little bit double vision, like blurry. I wonder if it needs to be repaired. I wonder if when was this thing repaired? Do we know? You see what I mean? Huh? I don't know if it's the dye or maybe it's my focus is not right, but I could still do the surgery fine, but we may want to take a look at it. It's not so bad right now. I think it might be dye leaking out because we did inject a lot of dye in this disc, and when you inject a lot of dye, that dye leaks out and it makes things blurry. So it may be just a blur. It may be the dye, Luis.
Okay.
I would just check the optics at the end, tomorrow,
Yeah.
and just see if the optics look good through the camera.
No problem, sir.
All right, so we're just about done on this side. We have the other side to do. Any questions from our audience?
Yes, we have about 2 questions. First one coming from Lanu on YouTube,
All right, Lanu, welcome.
asking, have you ever done a biopsy on herniation pieces?
Yes, of course. Every time we operate, we're doing a biopsy. A biopsy is just removing tissue and sending it to the pathologist. We send all of our herniated nuclear fragments to the pathologist for review. So we do it all the time.
Next question coming from Faisal on Facebook,
Welcome back, Faisal. Good to have you back.
saying, hi, doctor, hope you're well.
Happy New Year. Yeah, thank you.
As you are a neurosurgeon, I would like to ask you, if you have a benign bone tumor at only one place, what treatment would you do if the patient is in pain? Thank you.
Yeah, Faisal, great question. So, benign bone tumor, I would leave it alone unless I was 100% sure the patient was symptomatic from that tumor, which it's extremely rare that benign tumors would cause symptoms, very rare. Now, osteoid osteomas and osteomas can cause pain. If it's an osteoid osteoma, it'll have a characteristic appearance on CAT scan, and typically their symptoms go away, the pain goes away with anti-inflammatory medicine like Advil, Motrin, ibuprofen. So I would first of all want to know, is the pain localized to where the lesion is? Is that, like, wherever the lesion is, the bone lesion, is that where the patient has pain? Then I would try an anti-inflammatory like ibuprofen or Motrin, not sure what you have where you live. And if the patient's symptoms go away, then that's all I would do to treat it. I would not operate. Now, if the patient told me I have, ulcer or kidney disease or high risk for stroke, CVA, and they don't want to be treated with anti-inflammatory long term, then I would look at surgical option, taking it out, resecting it, because they're pretty easy to take out. Just depends on where it's located. If it's difficult location, dangerous location, I would not do surgery. If it's easy to get to, quick surgery, 1 hour or less, minimal bleeding, minimal symptoms, then I would offer surgery and do surgery. But I would first do a trial of anti-inflammatory to see if it responds.
Faisal commented left rib middle.
Left rib?
That's what he says, yes.
Well, I would personally want to make 100% sure it's benign. I would do all the appropriate tests. And if it is benign and the patient truly has pain from that lesion, I would try the anti-inflammatory. And if the anti-inflammatory works, but they don't want to keep taking it, then I would consider resecting part of the rib. The problem is that you're going to end up with possibly, what do you call it? The pain that people get after you do surgery on the rib. Forgot the name. What is it called? I mean, no, it's thoracic radiculopathy, but there's another name for it. So that would be the risk of the surgery, is giving them numbness in the skin, but also possible entrapment of that nerve that runs at the bottom of the rib. Now, I think a rib lesion is more risky to take out, because you worry about the lung. You don't want to cause a perforation that would cause a dropped lung. Right? A pneumothorax, you don't want a pneumothorax. A pneumothorax would be bad. Do we numb?
Yes, sir.
Yeah, a pneumothorax would be very bad. So that's what you're risking. And, not just the pneumothorax, but also the that's what it's called, intercostal neuralgia. Intercostal neuralgia. It's basically pain along the bottom margin of the rib that happens after surgery, where you either crack open the rib and do a thoracotomy, or you operate on the rib. Anyway, patient has to be made aware that that's a possibility, because if that happens and they get intercostal neuralgia, they're not going to be happy with you unless you can fix it. Very hard to fix. So you have to give them full disclosure of the risk associated with that procedure. I personally would try to avoid surgery for a benign bone lesion. Shot? All right, here we are, right L4-5. He's a little bit light, just a little bit. I can wait.
Faisal commented saying, "Thank you, doctor. It was an incidental finding, and I don't think it's causing pain. And it's been monitored for 1 year now. It's not grown."
Yeah, that's good. Hopefully it doesn't grow. It could be an osteoma. That's most commonly what it is. And just leave it alone. Don't take it out. God makes each of us different, and that's one of the differences that God puts. As long as it's asymptomatic, leave it alone. Now, we dealt with a lot of osteomas in neurosurgery because they can happen in the skull, and if it happens in the skull base, then you can get a pinched cranial nerve, And when you have a pinched cranial nerve, you can have what's called cranial neuropathy, which is a problem with the cranial nerve, either facial weakness or numbness or trouble with movement of your eyes. And those osteomas have to be surgically removed because they're causing neurological impairment. But thank God I don't see too many in the spine. Any other questions?
At this moment, no current questions.
Okay, we'll be done in 10 minutes. We've already operated on one side. We're going to do the other. We're at L4-5. He has both back pain and leg symptoms equally. The leg is actually a little worse. So we are making sure we're unpinching the nerves in the lateral recess and the neural foramen.
We just got another question
Sure.
coming from Faisal once more on.
Oh, look at that. Before we do anything, check it out. Check it out, guys. That is inflammation in the disc right there. We're going to need to use the laser most likely to clean it up. But that's where his pain and symptoms come from, that pink stuff. Okay? I just ripped part of it out. Let's get the laser. Laser's better. Go ahead.
Question from Faisal once more on Facebook asking from his follow-up, what causes them, doctor? Maybe I had them since I was a child, and
Yeah.
it was never found as I never had a scan.
Yeah. If it's an osteoma, they're just small benign bone tumors. They grow very slowly. Most people just leave them alone. They grow for like 20, 30, 40 years. Very, 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 very slowly. Low metabolism. What causes them? Genetic aberration. Basically, DNA has been misread by some cells, or you've had a mutation to some of the genes that code for bone cells like osteoblasts, and they in that area while you're being developed. I mean, the truth is, if you study science, if you study biochemistry, cell biology, developmental biology, microbiology, and genetic molecular biology, you realize that there is a miracle of life. Human beings, animals, plants, all life on Earth is a miracle that how it works, because the type of processes happening constantly at levels of billions of reactions every minute happening in your body and each body, and multiply this times billions of people and animals around the world. It's incredible what's happening inside of us. And for all those processes to occur and happen properly so that they give the result that it's expected, born out from time and evolution or God's plan, if you look at that and say, wow, how do all these things happen properly so many times every second, billions of times a second, and then you have one that happens wrong and it promulgates itself over time as an isolated lesion, you realize that that's amazing that all these processes have happened properly, and this is the one that didn't. You realize that it's a miracle that we have all these processes happening properly, correctly all the time, without tumors. It's amazing. Honestly, it's a miracle of life. That's why we scientists who understand it, truly understand it, we call it a miracle, because it is a miracle. That everything happens the way it's supposed to, you know? All right, there it is, the damaged disc right there. We're going to laser this and be done with it. This patient will be out of here in 10 minutes into the recovery room, and then he'll go home 30 minutes afterwards. Dr. B, I got 5 minutes left.
We have another question
Yes.
coming from Faisal once more on Facebook asking, the tear on the disc you're treating is red, right? Is that the color of the inflammation and blood, or just inflammation?
Yeah, the red is the inflammation. The tear is very big. This is all tear right here, but it's not pink, right? There's no inflammation right here. This is old inflammation. So I want you to think about what's happening in Ukraine right now, right? Russia is fighting Ukraine. Just think about that for a moment. Now, if you go to Ukraine, you're going to find many, many areas that are destroyed, old destruction. And then you're going to find a few areas then maybe 5% where there's active fighting that's happening, active fighting. If you look at this area right here, this is old injury, like old buildings destroyed from last month's fighting, or last year's fighting, or 2 years ago fighting, okay? When you find a little area of inflammation, like right there, you see that?
Yes, we do.
Right there underneath the laser, that's active fighting. This is where the front of the battle is. This is the battle front, they call it the battle front. And that's where the inflammation and pain are coming from. Now, when I go into the disc, I can't see these things unless you look and see them. So I clean all of it. And I clean the herniation out, because if you don't clean the herniation out of the tear, then the places that there's no fighting can come back and start fighting again. So you've got to just you've got to clean it all out so that the fighting never comes back to this place again. You're basically neutralizing the war with the laser and keeping it from happening ever again, as long as the patient doesn't re-herniate. 1% of our patients do re-herniate. They pick something heavy up when they're not supposed to. They do something they're not supposed to. They re-herniate. They've got to let this area heal. You've got to let the city rebuild and put the buildings back, put the infrastructure back, put the utilities back, put the transportation and roads. You've got to rebuild. The body has to rebuild this area. And just like it takes years to rebuild a war area in a real war on Earth in a city, it takes a year for the body to rebuild this disc. They've got to rebuild. Your body has to rebuild this. It's very slow. Once it's rebuilt, though, the chance of re-injuring it and more war happening is extremely low. It's not going to happen. All right, we're just about done. Probably 2 minutes left here. I hope that makes sense.
No current questions, but we do have a comment coming from Lanu once more on YouTube.
Yes, Lanu.
Saying, most neurosurgeons I met are quiet, but you are noisy in the best of ways. It's really nice to hear you talk and share your lifetime experience.
Thank you so much, Lanu. I believe in teaching people, and I've been teaching people since high school. I enjoy teaching subjects like science or philosophy or whatever it is I'm teaching. So the only way to teach is to talk and show. So I'm doing both. I'm showing and I'm talking. But thank you. I'll take that as a compliment. My wife, she says I talk too much. But then again, she talks a lot too.
We have another question coming from Faisal, once more on Facebook.
Yep.
Asking, Doctor, would in the future, after your procedure, would you inject PRP or stem cells to extricate the recovery?
Yes, we've tried it before, Faisal. It does not work. It makes the patient's pain worse. It does not help at all. We have done PRP. We have done stem cells. It is a bad idea. It causes much worse symptoms after surgery. We stopped doing it. We tried many years ago, probably about 12 years ago, with stem cells and PRP. I do not recommend it. It's also more expensive, but I do not recommend it. It does not help at all. It makes it worse. All right, we are done. I've cleaned all this herniation out. You can see it's gone. There's just a tiny bit left. I'll try to get that. And if I can't get it, I can't get it, but that's okay. We never get 100%. Those are fibers of the annulus, by the way, you're seeing. Any other questions?
Yes, we have a question coming from Aaron on Facebook.
Hi, Aaron. Welcome.
Asking, when is your next seminar, Dr. Duke? And when will you be presenting this technique at a neurosurgery conference/meeting? Where will you be presenting?
I don't know yet. That's a great question. I'm going to submit an abstract to the Florida Neurosurgical Society. I tried to do the Southern Neurosurgical Society with this very important discoveries, and they rejected it because they are absolutely corrupt and they are controlled by the industry that makes screws and rods and metal, and they do not want my treatment known to other doctors or the public. So they try to keep it from being known. All right? I cannot stop them. It's getting worse. I used to present my data and my surgeries at the American Association of Neurological Surgeons, the Congress of Neurosurgeons, the Southern Neurosurgical Society, the Florida Neurosurgical Society, the big spine meetings for AO Spine every year, like in Hong Kong I went. And I could tell you right now that the death stranglehold that the industry has on the agendas for these scientific meetings has gotten worse and worse and worse and worse and worse. When I first saw it happen, it was with artificial discs. It was 20 years ago. And the surgeons that were doing artificial discs these are the best surgeons in the country. They were having bad complications. They were reporting those complications at the meeting, and they were basically told never come back by the companies that make the artificial discs, and they shut the meetings down. Okay, they closed it down. So that's the power that these companies have over our data and our knowledge, and it's gotten worse. I thought back then it was artificial discs, which I didn't care so much about. I was doing them, but I didn't think they were very good. I'll hold pressure. And then now I see that it's affecting my surgery, my treatment. So the companies like Medtronic and DePuy, Johnson & Johnson, NuVasive, Globus Spine, these big multi-billion-dollar companies that make billions and billions in profit every year selling the metals and the stimulators, Boston Scientific is another, Abbott Spine. These companies do not want this surgery known, taught, talked about, presented, discussed. They don't want the public to know about it, and they want doctors to know about it. Because good doctors will say, wow, I want to do this instead of putting metal in my patients. And they don't want that. So they have literally shut down truth on a national meeting level and internationally as well. They control all the information, and they are using their power to basically shut down any opposition. That's why we broadcast independently at Duke Spine every week, because they can't shut us down. They can try, but and they do try, but we're still here broadcasting for you guys to give you the truth. I don't know what meeting I'll be presenting at next, but I'm going to try to submit my research to the Florida Neurosurgical Society, FNS. Look it up on Google, Florida Neurosurgical Society meeting. I'm going to get my son to submit the abstract that we worked on, and hopefully they'll accept it and allow me to present. So we'll see. Even that society is also corrupted. Okay, so it's always a crapshoot to get the truth out. Running the gauntlet. Any other questions?
No current questions.
Thanks for joining us. We're signing off for Thursday, January 23rd. We'll be back hopefully next week with more surgeries for you. Do we have any surgeries next week?
Yes.
All right.
I think there's like 3 on Monday, 2 on the other.
On Tuesday and Thursday. All right, so it sounds like we have surgeries on Tuesday and Thursday next week. So please join us next week for more exciting live spine surgery and conversations with Dr. Duke Majan. Thank you.